Good morning, everyone. Thank you all for joining us on this lovely Thursday morning. We are super excited to be hosting this webinar on low back pain, and we've got a ton of great information to share with you. I'm Olivia with Ethos Integrative Medicine, and I'll be moderating this webinar. Before we start, please remember to mute your microphones, and if you have any questions, feel free to type them into the chat. We'll be sure to answer them at the end. If you have any questions specifically regarding to your personal care, we cannot address that in our webinar, but I highly recommend scheduling a free 15-minute consultation with Dr. Massingale, and she'll be able to answer your questions and help you to navigate treatment options. So without further ado, I'd like to start our webinar by introducing Dr. Morgan Massingale. Dr. Massingale recently joined Ethos Integrative Medicine after completing her residency training at the Neil Riordan Center for Regenerative Medicine at the Southwest College of Naturopathic Medicine. While there, she focused on image-guided regenerative injection therapies, specifically on spinal conditions. We're super excited to have Dr. Massingale host this webinar today and join our practice to expand the depth of services we are able to offer our patients. So thank you.
Thank you so much, Olivia. I'm really excited to be here and start meeting some of the contacts and patients associated with this practice, and really bring my expertise and help guide people in the right direction. So taking back your back, why is this of interest to me personally? There's an old adage in medicine that every physician goes into medicine looking to either treat themselves or treat a loved one, right? I am not exempt from that. As a 17-year-old varsity athlete, I threw my back out for the first time. Living in Kansas City, Missouri at the time, the people that were, in charge of my care were my pediatrician and the limited kind of athletic training staff that we had at the high school. Unfortunately, I missed my entire senior season because of this injury. And the people that I was working with at the time weren't really equipped to understand or dig into why a 17-year-old developed non-traumatic back pain. It actually wasn't until I was in my early 30s that I started to get some answers on why I had these, persistent pain conditions. So that's kind of what led me down this path of wanting to specialize in spine and in regenerative medicine. A little bit more about me in particular. I graduated from Georgetown University with a master's in physiology and biophysics, and I actually spent 7 years in the pharmaceutical research industry, working specifically with orthopedic conditions, mostly post-surgical pain management. So I've been in the orthopedic field for a while, in that surgical realm, looking at pre and post-operative care. So I'm well-versed with, the physical therapy and a lot of the allopathic modules that patients go through in that allopathic realm. What I saw and experienced in my time in the pharmaceutical research industry really led me down the naturopathic route. And I ended up attending the Southwest College of Naturopathic Medicine and becoming a physician focused in regenerative medicine as a second career. After I finished my naturopathic training, I actually did the 2-year residency at the Neil Riordan Center, like you mentioned, continuing to hone and focus down in orthopedic regenerative medicine and specifically image-guided injections. So why are we talking about low back pain today? Unfortunately, according to a lot of the recent studies in the epidemiology world, 80% of Americans will experience back pain at some time in their lives. With a population of 330 million people, that's a lot of people that are going to experience back pain. For a lot of people, well, for a subset of people, that will become a persistent chronic condition. Low back pain, they estimate that there's about $50 billion that is spent in the healthcare industry trying to address this. And unfortunately, a lot of people don't come to long-term resolution with the options that they're presented, leading to an overall loss in productivity. But more importantly, what I feel is a loss of enjoyment of the activities of your daily life, right? If you're unable to attend your daughter's concert because sitting for a long period of time is too painful for you, or you're unable to exercise or travel or play with your kids or your grandkids, that's a huge burden that you shouldn't have to live with. You should know what your options are, know who you can talk to, and know what your resources are to get you back to what you want to do. So today we're going to talk about 3 common causes of low back pain. These are not, it's not an extensive list, but these are things that I see most commonly in my practice. We're going to talk about some sacroiliac joint dysfunction, some lumbar facet arthropathy, and inflammation of the cluneal nerves. Depending on your background, you may or may not know what any of those things are, but we're going to dive in a little bit, kind of talk about what causes those things, what predisposes you to them, and then kind of what your options are moving forward. So the most common cause that I've seen in my practice of low back pain is sacroiliac joint dysfunction. There's actually a running joke in my residency program that low back pain is sacroiliitis until proven otherwise. So some of the telltale symptoms that patients will come in complaining of, they have pain that's exacerbated when they go from a seated to a standing position. They're having difficulty lying flat on their back. And a lot of times, because you are predisposed to this sort of dysfunction when you have loose ligaments, you'll find yourself really unable to sit still in your chair. You're constantly shifting weight, fidgeting a little bit to try and create a more comfortable position for yourself. And sometimes it's just not able to be achieved, right? So what exactly is going on here? So the sacroiliac joint is in that little red circle there. And a lot of times, like I kind of mentioned, ligament laxity will lead to instability in that joint. And then the surrounding musculature, so a lot of times your glute medius or your glute maximus that I have on the picture there, will try to tighten up to stabilize that joint and prevent that excessive motion that's happening. Unfortunately, that leads to pain in that region. A lot of times patients will come in with that low back pain. It will be also in their glutes, and then sometimes actually radiate their leg with sciatic type symptoms. Why this is happening when those gluteal muscles are to pick up that work that the static stabilized the ligaments aren't able to do, they start to spasm and they start to contract inappropriately, which kind of clamps down on that sciatic nerve that runs down into that region, down through the leg. So I often see this, misdiagnosed as sciatica. Why do we have ligament laxity? Good question. There are a few conditions that really kind of leave us predisposed to this. Chronically high stress will lead to poor sugar metabolism, which leads to poor collagen production. So when you have patients that are chronically in situations where they're in high stress mode, you start to see kind of some ligament laxity develop. This, in conjunction with the fact that most of us sit all day long, leaves the musculature imbalanced, and it leaves us with a really bad recipe for low back pain. Another condition that can lead to some ligament laxity and lead to the sacroiliac joint dysfunction is pregnancy. The body is very smart. When we are in the later stages of pregnancy, the body starts producing a hormone called relaxin, which tells the ligaments to loosen up a little bit because that pelvis is going to have to do a little bit of expansion for natural childbirth. Unfortunately, that does leave that sacroiliac joint at a little bit of a disadvantage, and SI pain is very common in pregnant women. There are also genetic predispositions to ligament laxity, such as Ehlers-Danlos syndrome, which is the less severe, less scary cousin of Marfan syndrome. So in this condition, patients aren't able to form collagen correctly, so their ligaments just aren't as solid as you might hope or expect. There are variants where that's the only thing that you see, but there are also variants where there are some other conditions that we need to keep an eye out for in the cardiovascular system, most importantly. So that's why it's really important to have someone evaluating you that kind of knows all of these things, knows other systems to keep an eye out for, and isn't just pinpoint focused on your musculoskeletal pain. Another condition that I see that contributes to low back pain with some of these radiating symptoms into the leg is lumbar facet arthropathy. So the lumbar facets, which you'll see, one of them circled in this little red circle here, allow for that motion in the spine that's going to let you rotate, laterally bend, extend, look up towards the ceiling. And telltale symptoms here are pain with those types of movements. Because of the proximity of these joints to the spinal nerves, inflammation here can mimic some sciatic type symptoms as well. You might see pain, numbness, burning down into the lower extremity, but it doesn't have that true sciatic pattern, right? So the nerves that actually innervate this capsule are the medial branch of the dorsal root. And a lot of times, if you've had anyone that has had like an ablation type therapy to address their low back pain, this is of what our tissue is those nerves innervating the capsule. Again, these symptoms can be confused with sciatica, and if you are not treating the correct tissue, you see resolution of the pain. The last kind of condition that we're going to talk about is cluneal nerve inflammation. So your cluneal nerves are part of your superficial nervous tissue. So just in that tissue underneath the skin, deep to the fascia, but above that muscular layer. So you'll kind of see them on this little diagram here. You have the superior cluneal nerves right at the top of the hip, and cluneal nerves right over that sacroiliac joint. When nerves become entrapped in their surrounding connective tissues, which is known as fascia, sometimes they become swollen, they become irritated and inflamed. So some of the telltale signs of nerve inflammation as opposed to problems with the deeper structures, this is going to be better with rest and worse with movement. A lot of times when you have your Sacroiliac dysfunction or your facet arthropathy, you'll see that you'll be kind of a little stiff when you first get up and get moving, but with continued motion, sometimes that loosens up and it's a little bit easier as you go throughout your day. Nerve inflammation, on the other hand, is going to be worse with that motion. I'm not going to alleviate. And a lot of times with cluneal nerve inflammation, you won't see those radiating symptoms down in the leg. So the next thing to talk about is the conventional options that you may be offered by an orthopedic surgeon, your primary care physician, somebody like that. It's always good to know what your options are and what you're weighing out, right? So non-steroidal anti-inflammatory drugs are often a first-line treatment for a lot of these low back pain conditions. Over-the-counter options include like Advil, Aleve, things like that. There are prescriptions such as meloxicam, medications like that. Long-term use of NSAIDs, we want to be wary of just because they do have an impact on the gastrointestinal system. Namely, long-term use can lead to ulcers and that sort of thing. You may also be offered or have been offered narcotic pain medications, such as like hydrocodone, Norco, oxycodone, that sort of thing. I think we're all pretty well aware of the opioid epidemic as it exists in this country. Most of the time when patients are prescribed narcotic pain medications for pain, they don't develop a overt addiction. However, the body does become acclimated to doses of narcotics over time. So you'll see that pain becomes less able to be controlled at a lower dose, and you have to increase the dose as you go along. So long-term use, not really great with narcotics either. Another option that exists is steroid injections. Steroid injections, they have their time and place, just like all of these things that we have discussed and are going to discuss. However, patients need to be aware of both the short-term and the long-term risks of steroid injections. So short-term, you can have blood sugar dysregulation. So if you have any pre-existing conditions like diabetes, this is something you really want to be aware of, because having your blood sugar controlled for a few days after a steroid injection is going to be pretty difficult. Long-term, steroids aren't doing you any favors. They do immediately calm down inflammation, and they're great at that. But repeated injections into a joint can actually degrade tissue, so break down cartilage and break down the integrity of the ligaments and tendons surrounding a joint. So, that's actually why if you've ever had a steroid injection, you can't have more than a certain number of them in a year because that is a known effect. Ablation therapies are an option that exists out there. You actually go in and just burn out that nerve that's sending the signal. There's a number of issues with this. First of all, when you burn out those medial branches, like we talked about with the facet arthropathy, those nerves are also actually responsible for innervating the multifidi muscles. So what are those? Those are the small muscles in the spine that allow for the segmental rotational movement. If you're burning out those nerves, you're making the spine less stable overall, which can lead to quicker development of conditions like osteoarthritis and conditions like that. We've also found, as ablation therapies have been around for a longer and longer period of time, that the nervous system is way more plastic than we ever give it credit for. So what does that mean? It means that the nervous system is actually able to adapt even into full adulthood. So if you're going in and burning out nerves, they likely will grow back after a period of time. So it's not a one and done therapy necessarily. Physical therapy exists in the allopathic model. I will not knock physical therapy. It is definitely part of any treatment plan that I'm doing with regenerative medicine. But something to keep in mind is that you should be working with the physical therapist that is well-versed in your condition. There are different specialties within the physical therapy world. And someone who knows how to address you and address your condition is going to be very important. And lastly, there are, in the conventional model, surgery. The success rate for surgical procedures of the spine is currently quoted by, Mayo and other well-known places like that to be about 50%. I don't know about you, but if I brought home a 50% grade, I never did. But if I had, that would not be an acceptable grade to come home with. So knowing the risks and benefits of a surgery and the possible outcomes there is definitely something to consider. There are patients that surgery is the best option for them, and I'm not going to dissuade someone if that is, their best course of action. But making sure that people know what their other options are is really important. So what is our approach here at Ethos? We kind of have this 4-point model that we use to think about any joint issues, and that includes issues with spine. So we want to make sure that the body is working symmetrically. If you have pain, a lot of times the body will compensate around that pain. If it's something that you've been working with for a long time, especially, you need to make sure that all of the muscles in and around that joint and in the kinetic chain that is attached to that joint are firing appropriately. And it's best addressed by, sometimes chiropractic, but definitely physical therapy. Articulation. So what does that joint actually look like? Has the cartilage started to degrade where those two bones come together? Is that something that we need to address with either an injection therapy or, are you more a surgical candidate? Stability. We want to make sure that the static stabilizers, so your ligaments and tendons, are doing their job, holding the joint in place, and also the dynamic stabilizers, so the muscles in that space are pulling their weight and they're firing appropriately and doing their job. We can address this with regenerative injection therapy, as well as, again, really harp on the physical therapy part of what we do. Neuromuscular, so making sure that the signal from the brain is getting down and firing appropriately, and also that the message going back is happening appropriately. So if you have neurologic pain fibers that are misappropriately firing, like we see with the cluneal nerve inflammation, we can help reset that pain signal and get it messaging more appropriately. Also making sure, like I said, that the signal is coming down from the brain and firing muscles appropriately, and allowing for appropriate movement within the joint itself. So how do we give you the best treatment? Building a treatment plan is really specific to individual patients. We need to understand what your personal goals are. If a treatment plan includes getting you to completely stop doing something that you love to do, it's not a great treatment plan for you. I have worked with patients in the past that their thing is triathlons. And I've had other practitioners tell them that, nope, you're never going to do another triathlon, and that's the only way you can be out of pain. That makes my heart really sad. Part of the treatment plan may be backing off of a certain activity for a while, allowing appropriate healing. But we do want to make sure we're getting you back to your goals, making sure we're getting you back to what makes you happy. So how do we do that? We definitely do a comprehensive evaluation, come in, get a thorough history of, is this a traumatic injury? Is it non-traumatic? How long has it been going on? And getting an accurate diagnosis is really, you need to be hands-on with musculoskeletal conditions. So having a very thorough physical examination is important with these conditions. Sometimes that's enough. Other times you will be referred for imaging. So either x-rays or MRI, those are appropriate. And then building that customized treatment plan for you. That includes, any regenerative injection therapies, but what we want to do is really prime the body to receive that injection therapy and heal at its greatest capacity by working with a lot of our other partners. So we have some really great physical therapy offices that we refer to. We also have nutritionists that we work with, because a lot of times pain is like a body's smoke signal, right? If it's sending up a signal in a certain area, but it's in the middle of a forest fire because your body is so inflamed from your diet and lifestyle, we're not going to be able to pinpoint and address that and hear the message really clearly and well. So we kind of need to clean up the environment sometimes before we go in and regenerative medicine. You also want to make sure that you are a good candidate for the level of injection therapy that we choose for you. So we'll talk a little bit about prolotherapy in a minute and how that's an umbrella term. But there are different levels within that may be appropriate or not appropriate for your case. And that all that together really stacks the odds in your favor of having a good treatment and a good response. So like I said, you're just getting the most out of your treatment, stacking the odds in your favor, which may include, any IV therapies if your nutrient status is deficient, supplements, making sure that with focused nutrition, you have the building blocks that are necessary to heal, making sure you're getting enough protein in your diet, a variety of antioxidants, that sort of thing, and then modifying activity as appropriate around your injection therapy. Our focus and our way of treating, I think, is really important here at Ethos. And it's important for patients to understand that we are not an injection mill. I've seen a number of clinics that is the way they operate. They take images and they put a needle in that spot and you go on your merry way. Unfortunately, I see a lot of treatments in that model fail because they're not taking into account all of these other factors that are going to put you at your best advantage and give you the best opportunity to heal appropriately. So that being said, I like to focus on the injection part of this whole thing. One of the things that I have found is that if you are a jack of all trades, you are a master of none. So one of the things that's really important in the way that we work here at Ethos is having strategic partnerships with other offices. And I kind of mentioned before, we have physical therapy offices, nutrition, strength training, if that's appropriate in your case. Kind of a little chuckle with my trainer earlier this week that you know, people get into strength training, especially in January around New Year's resolutions, and they go in on their own. They haven't exercised in 20 years and they start doing something as simple as a glute bridge. If you're not engaging the glutes correctly and you're taking that arch all the way up into the low back, you start stressing inappropriate things. And every exercise is a low back exercise if you do it wrong enough. So making sure that you have someone who's really well versed in you going in the right direction in a safe and effective manner is important. So I'm going to circle back now to regenerative injection therapy. So the umbrella term is prolotherapy, prolo being short for proliferative. So all of these injection therapies are targeted towards helping proliferate tissues, so helping them regenerate and helping heal. The kind of most traditional level of prolotherapy is dextrose. So it's a dilute sugar solution paired with a local anesthetic that is injected into the target tissue. The best and strongest action of this type of injection therapy is to tighten ligaments and tendons. It can also have good effect inside of the joint, helping with cartilage. However, I see kind of better benefit with platelet-rich plasma at that. But back to the Perlo, if you have a condition where some of the ligament laxity that we talked about earlier is contributing to your condition, this might be a really good option for you. Kind of up from that is platelet-rich plasma. So we take your whole blood, we spin it down, and we capture the little portion that is the richest in growth factors. And that's also where your platelets reside. So you'll see the little diagram here of how the blood spins out with the plasma on top, red blood cells on the bottom, and the good stuff that we're looking for right in the middle. So we take that out and actually inject it back into the body to help stimulate healing in the tissues. Another step up from that is stem cell therapy. We do not offer that here at Ethos. The only true stem cells that you have out there are bone marrow derived and adipose derived. Stem cell products that you may see marketed at other offices are not live stem cells, and they're very good at which is also achieved in your platelet-rich plasma. So knowing that that option is out there is important. I have a colleague that used to give an analogy of the different levels of prolotherapy. So dextrose therapy, you can think of it in terms of your yard, right? You go out every weekend and you trim the bushes and you mow the grass and you kind of maybe you edge some things. That's what Prolo is doing. It's kind of doing a maintenance cleanup. It's going to make everything look better, feel better. Up the level, platelet-rich plasma, maybe you have a little gopher that's gone crazy in your yard, you need to patch up some holes. But overall, your yard still looks good and it's, you know, not heavy duty maintenance. If you're at the level where you're needing stem cells, you need a whole darn new yard. I mean, you're looking at sod, you're looking at new trees, you're looking at new bushes. So it's kind of, you know, the levels of prolotherapy that we think about. And most patients I have found are not at the whole new yard level when they come in to see me. One of the next things I want to talk about are perineural injections. So this type of injection therapy is going to be best to address that superficial nerve inflammation that we talked about a little bit earlier with the cluneal nerves. It targets that subcutaneous nerve tissue. It's a fairly shallow injection, very short needle, less intimidating. And it's a very dilute sugar solution, so it's 5% dextrose, which attaches to a nerve receptor called TRPV1. Most patients are familiar with this, they just don't know they are. A lot of us have heard of capsaicin used topically. Capsaicin also attaches to this TRPV1 receptor, but as opposed to capsaicin, which its goal is to go in and kind of tire out the nerve, the perineural injection therapy, so the dilute sugar, actually attaches and kind of helps calm and reset that nerve. I kind of liken it to a lot of my patients like hitting a reset button on that pain signal is being fired up to the brain. And then actually, very interestingly, we found that through a concept known as Hilton's law, these perineural injections can actually affect some of the deeper structures. So the nerves that run in the skin that provide that, that pain sensation come from the same nerve root as the nerves that are innervating the joint and the muscles in the area. So you can target those more superficial nerves with your tiny needle, help reset that, and it kind of sends its message back to the spine, which then tells the other nerves that, hey, you can relax a little bit, stop sending off this mean, angry pain signal. So I just wanted to let you kind of share an experience that I've had already at the Ethos with a patient that I've had with low back pain and what we've been able to do for her. So I had a 6-year-old female present with low back pain and right hip pain that had been persistent for about 6 months. Pain she reported was a 9 out of 10 at its worst, and she was experiencing a burning sensation in the right lower leg and the foot. Her onset of pain was while she was lifting weights. So we ended up through physical exam and imaging, diagnosing her with some lumbar facet arthropathy down at L4-5, L5-S1, and some sacroiliac dysfunction. So fun fact, patients don't have to have just one problem. You may have a number of things that add up to your particular picture, right? We opted to do some traditional dextrose prolotherapy with her. And approximately 2 weeks after her first prolotherapy treatment, the intensity of her back pain was decreased and less frequent. The intensity of the burning sensation that she's having in her lower extremity is less intense. And she was able to return to yoga, which she hadn't done in nearly 6 months since this pain condition began for her, because it was really aggravating going into some of those positions. So, she's not done with treatment, but already she's seeing a great benefit from that holistic approach that we're taking with her, added in with the injection therapies. So what can we do for you? Well, let's find out. I'm assuming today that, if you've joined us for the webinar, that either you or someone is experiencing low back pain. So one of the best things that we offer here at Ethos is actually a free 15-minute consultation. We can talk specifically about, your case and what treatment options may be the best for you. I really like this 15-minute free consult, because choosing a doctor and choosing a practice that you're going to work with is a lot like choosing a partner, right? You need to make sure that we're going to fit, we're going to jive, that our approach makes sense for you. So if that's something that would be interesting to you, go ahead and private message Olivia, who's going to jump on in just a second, or you can give the office a call and set that up at your convenience.
All right, thank you so much, Dr. Massingale. This was a really great and informative presentation, and we really appreciate you taking the time to share your expertise with us today. So at this time, if you have any questions, please feel free to type them into the chat, or you can private message them to me if you want to be anonymous. We can answer them for you. Please remember, if you do have any specific questions relating to your personal care, we can't address that, but I highly recommend calling us to schedule a free 15-minute consultation with Dr. Massingale, and she'll be able to answer your questions and help you to navigate these treatment options. So if you have any questions, feel free to type them in the chat. I'll wait a few minutes just to see if we have any pop up. Looks like we have a few that are typing.
Stop sharing there. There we go.
All right, so we have our first question. What treatment might be different for patients who have already had tissue damage due to steroids? This is a really great question.
Yeah, so those patients are still candidates for regenerative injection therapy. They must take a little bit longer to respond. So typically we see resolution and really great response with 3 traditional dextrose prolotherapy treatments. They may be more on the 5 range, because they're, they do have that tissue integrity damage. Making sure that they have good nutrition on board is definitely going to be important. So making sure they're getting enough protein in their diet, supplementing with collagen can actually be beneficial sometimes. And also making sure that they have, the vitamin C, lysine, that sort of thing to help the body have all of its building blocks in place as we go in and stimulate that healing response.
Awesome. Are there any common questions that you commonly interact with from patients about low back pain?
I missed part of the question. I'm sorry.
No, it's okay. I was just wondering if there are any specific questions that you interact with often from patients regarding low back pain, like if there's an exercise that they've done or something.
Yeah, so I've actually had a number of patients recently that came in because they hurt themselves while lifting weights, and that's kind of why I touch on working with someone that knows what they're doing and can help you with appropriate form. Another thing that I see commonly that is confusing for patients is that I don't treat imaging. Imaging is valuable and I do order it and it is useful. However, by the time we reach a certain more experienced age, a lot of us have degeneration of our discs and some herniations. Whether or not that's causing your particular pain and your particular symptoms is really up in the air. You have patients that have wildly desiccated discs and bulges and herniations that are walking around completely pain-free. So you really have to look and correlate imaging with the symptoms that patients are experiencing. And that's really important.
Another question that we have is, can you talk about how 80% of individuals with chronic low back pain having reduced CSA, fatty infiltrates, and scar tissues? How do you approach that?
It can be really difficult, to be honest with you. Scar tissues, especially from previous surgeries, are highly sensitized, so they have extra nerve endings in there, and they can actually lead to increased pain with injection therapies. So knowing how to go in and break up scar tissue, you can do some scar therapy, especially if the fascial layer has become kind of trapped and isn't gliding appropriately over muscles or not allowing movement. You can go in and do hydrodissections of that to get good movement of that tissue again. Fatty infiltrates are difficult. PRP injections into, actually I prefer to do PPP, so platelet poor plasma into muscle bellies can help regenerate within the actual muscular tissue. PRP, so platelet-rich plasma, we try to use more in the tendon insertions or ligaments. So platelet poor more for inside muscle, platelet rich for the tendon insertions. So there's some of the therapies that we have that we can kind of address those additional things that are going on with patients.
And then we do have one more question in the chat here at this time. What treatments might be best for bulging herniated discs in the lower back, specifically around L5-S1 area? Yeah, so
like I said, I definitely want to make sure that that's where your pain is coming from. And if it is, we do have options for that. So you can do epidural injections to target the specific nerve that's being impinged by the herniated disc. That's done under a different type of imaging than we have here in the office. So it'd be something that we would work with another imaging center to accomplish. But a transfemoral epidural can be really helpful in that situation. Nerve roots that low, so L5-S1, you can actually sometimes affect by going in through a caudal approach. So the spine where your sacrum attaches to your tailbone, very far away from the actual nervous tissue, the dural space. So, that's something that is an available option as well.
Awesome. Does anyone else have any more questions? I'll just take another couple seconds to see if we have any in the chat. But thank you so much for everyone for joining us today. We hope you learned something new, learned about some of the treatment options we've done here, and we're super excited to have you, Dr. Massingale, join our practice. Thank you so much for joining us today, everybody.
Thank you.